Hey, it's Patty. In this presentation, I'm going to talk about the clinical presentation of hypermobile Ehlers Danlos syndrome and hypermobility spectrum disorder. So what are we seeing in these individuals? So we're going to branch outside of hypermobility. We're going to talk a little bit about that, but what else do we see? Because this is not just hypermobility, this is a connective tissue problem, right? So just for individuals that are dealing with it, practitioners that are seeing it, family members as well, so that we can get a better idea of this is not as reductionistic as I think it seemed before of just a ligament problem. But really, what do we see globally in these patients? So hopefully there'll be more general information in this presentation. So the difference between hypermobile EDS and hypermobility spectrum disorder is a checklist, right? So those that have hypermobile Ehlers-Danlos syndrome have fit into this 2017 clinical diagnostic criteria for hypermobile EDS. Yes, if you were diagnosed before 2017, it's written that you can keep that diagnosis, but after 2017, we do rely on this clinical checklist that we'll run through, not in detail, but just to understand what we're looking at and why. It reviews hypermobility and also systemic involvement, right? So we're seeing, again, more connective tissue problems rather than just hypermobility and ligament problems. It's more of a global type problem, genetic related. Hypermobility spectrum disorder is also a group of the symptomatic hypermobility characteristics, but it doesn't fit into the 2017 clinical diagnostic criteria. But it still indicates that there's an overall connective tissue pathology that's happening, not just hypermobility, but this spectrum disorder that we're seeing, this reaction that's happening in other connective tissue of the body. So the difference is the checklist, right? So the importance to understand, and as providers, you'll hear a lot of us say, or some of us, I should say, not all of us, that hypermobile EDS treatment-wise is considered the same as hypermobility spectrum disorder until proven otherwise in the genetics, right? But we have to treat the individual that's in front of us, and that's why knowing how this condition affects all the different systems can help provide better treatment strategies and outcomes. You still have to look at the individual. We're looking at an underlying connective tissue disorder, right? We need to change the language on this. Hypermobility is a symptom of the condition. Hypermobility for a lot of individuals that have this is not the primary problem. It might have started that way, but we have this domino effect because connective tissue is in other areas of the body. And sometimes the joint presentation is the first that we notice or see. But then when we add inflammation to these presentation, that's where we have the domino effect of the other connective tissue showing you that it also has efficiency problems. We have these different classifications for hypermobility spectrum disorder, right? So there's a spectrum that's out there. It's divided up, and this actually includes all of the HSDs in it. But then we have the asymptomatic generalized joint hypermobility. And this is the group that we say, hey, there are some people that can just be hypermobile out there. We don't have systems that are affected. It doesn't seem to be the connective tissue throughout the body, but there seems to be joint related stability issues. When you have an underlying connective tissue disorder, like something within the EDS or the HSD family, you have other systems involved because it involves more connective tissue outside of just the joints. And that's where, again, multiple systems become involved, especially the more wear and tear, or especially the more inflammation that's not brought under control. Now with HSD, that's kind of the second half of this list here. So we have generalized hypermobility spectrum disorder. So that's what we see is very, very parallel to our HEDS population, right? There's more global type of hypermobility that's present. They may pass the Baton score, but we don't have them passing feature A, B, or C. So generalized hypermobility spectrum disorder, very, very similar to the presentation clinically of hypermobile EDS. Maybe we missed a few of the check marks that were on that list, though. Peripheral hypermobility spectrum disorder, this talks about the peripheral joints, which means it's further away from your core. So fingers, those that have more finger, hand, wrist, toes, ankles, but maybe not hips and shoulders. That would be more of the peripheral hypermobility spectrum disorder. Localized can happen as well, and this could be limited to single joints of the body. So maybe somebody really just has a lot of shoulder laxity and other systemic stuff happening that seems to be connective tissue in nature, or maybe it's just the ankles or the knees, but we're not seeing it globally, or we're not seeing it match in the hands and the feet on both sides. And then we have this group of historical hypermobility spectrum disorder, which are the people that maybe could have at some point, but they just can't demonstrate bringing their thumb to their forearm or pulling back on their pinky. So, and this is the Baton score is, we're not going to get into too much detail with that today. We talk about that all day. It's the Baton score is there to help out medical providers across all fields because not everybody is taught to test for joint hypermobility. So Baton score actually looks a lot at flexibility, and sometimes we do see that crossover. But people can be lacking on the Baton score and still have globalized joint hypermobility, which we'll talk about a little bit more, what we might do for those. But even in my test, I mean, I still have a good amount of flexibility, but if you look at my two sides compared, I just had an injury. I mean, my fingers take forever to heal, but I just had an injury on this right side, probably about 6 months ago or so. So I've lost a lot of mobility compared to this one that is just nice and bendy. And it happens in thumbs. People lose mobility recovering from injuries or old injuries that haven't recovered fully. So you can lose mobility in certain joints. And we can see that in the hands too, or you can have muscle tension and things like that. So historical hypermobility spectrum disorder allows the individual to tell you if they had that hypermobility present, if they used to be double jointed back in the day, if they could do the splits, but they aren't able to do it now, right? So we actually might have more of our older generation looking at connective tissue disorders be put into this group if we can't have them pass the 2017 clinical diagnostic criteria, although there is some wiggle room in there as well. So again, generalized joint hypermobility spectrum disorder, or GHSD, and I know there's so many initials in here. GJH is generalized joint hypermobility. So in other words, generalized means it's kind of global and throughout, it's consistent. We see hypermobility throughout multiple areas of the body, tends to be on both sides. We can use the Baton score for this one. And we're also seeing, so this is where the connective tissue problem comes in. It's not just hypermobility, but we see one or more secondary musculoskeletal manifestations identified. So we see other things that might also be present, whether it's chronic pain associated with this, or we can sometimes see some systemic issues as well. Very, very similar. The peripheral, again, you can see that the important thing here is to see, we see the peripheral, the joint hypermobility that's in the hands or the feet, and we see one or more secondary musculoskeletal manifestations, right? So localized, again, we're seeing localized, possibly single joint, and then also these secondary musculoskeletal. So we're seeing more than just the joint hypermobility. Okay. Historical joint hypermobility spectrum disorder. Again, this is the history of that if somebody isn't able to show you. But the physical exam itself, we're trying to exclude the alternative diagnosis of these other hypermobility spectrum disorders and also other rheumatological conditions as well. Especially as we get older, there might be more of an autoimmune type of presentation that builds up over time. So just to understand that there can be an overlapping, of course, absolutely. We're seeing this more and more even in our younger population as well with connective tissue disorders. But it's just good to know what the individual needs to be treated for. We would want to know if they have something within the hypermobility spectrum disorder and also an autoimmune pathology. It can be very beneficial for treatment. So again, what's the difference between hypermobile EDS and hypermobility spectrum disorder? A checklist. It's just a checklist, right? Both will indicate that there's an underlying connective tissue disorder that's happening. It's more global, it's throughout the body, it's not limited to the joints. We're seeing it in other areas as well. They're very similar in presentation, their symptoms, and also functional limitations, right? So very similar. And this is what the clinical 2017 clinical diagnostic criteria checklist looks like. A lot of patients know what this looks like. A lot of patients fill this out on their own before they go see their medical providers. What we're looking for is basically positive responses in criterion 1, 2, and 3. So that's why this is, when they brought this out, it reduced the number of people being diagnosed with hypermobile EDS and more people being put into generalized hypermobility spectrum disorder. Important to understand, it does not mean that the care changes based on either one of those diagnoses. And I'm saying that to providers as well. It does not mean that one condition is less than the other. This is just a checklist that we have now that will probably change as we learn more and more about the genetics and presentations and these different phenotypes that are popping up too, right? So for an hEDS diagnosis, you do need to have a positive Baton score. You need to have 2 of criterion 2 that come back positive of features A, B, and C together. And then the last part is actually ruling out other pathologies, which this gets a little bit of a gray area for a lot of patients and providers alike, because we do know that you can have coexisting conditions like autoimmune pathologies and connective tissue disorders a little bit different. So the Baton scale, we're not going to spend too much time on this because I really want to talk about the clinical presentation. But like I said, the Baton scale is something that we use because it's easy to implement for individuals that don't know how to check for hypermobility. Looking for hypermobility is typically carried out by physical therapists, some occupational therapists, and then orthopedics, DOs, chiropractors as well, right? But not all doctors are trained to figure out if you are hypermobile or hyperflexible, and there is a difference. But the Baton scale looks at the small finger, pulling the small finger back, looking for more than 90 degrees, bringing the thumb, EDS gang sign, right? Bringing the thumb down to the forearm. Technically, this is supposed to be done with the elbow straight, just so you know, within the clinical diagnostic criteria. Elbow hyperextension greater than 10 degrees. So we're measuring the hyperextension of the elbow when you bring your arms out to the side. And this is the individual can really try to hyperextend in that position. And then the same with knee hyperextension. We have them stand and really try to press the knees back behind them. Knee hyperextension is really, really difficult to tell what the actual measurement is just because of the biomechanics and the shape of basically where the bony alignment is. And then even for like smaller individuals or people that have a good amount of muscle, it's hard to tell where that greater trochanter is and the knee and then coming down to the fibula. So if you're not trained in goniometric measurement, figuring out if you're more than 10 degrees can actually be difficult. And I find this is one of the most common things that's missed because most people don't know how to look for knee hyperextension, right? And then palms to the floor. Can you keep your knees straight and bring your palms down to the floor? And now some people used to be able to do this, can't do it. Also, a lot of people are driving in cars for a long amount of time, tightening up that fascia. That's another one I see that a lot of people can't do, especially if we have neurological tension. So that's a tough, I hear all the time, well, I could if I warmed up, and I believe them. But again, the test is right now in the moment, can you bring your palms to the floor? And again, I'm not going to go through all of these, but what I wanted to do is just show you, talking about that clinical presentation, right? Feature A is where we move a little bit away from joint hypermobility and we see, hey, are we seeing any abnormal connective tissue in other parts of the body? Any abnormal connective tissue healing responses? Do we see any of that? And that's what this feature A goes through. So do they have soft or velvety skin? Now, I can't tell you how many people have no idea because they don't go around touching other people's skin. So of course you can compare it to other people, maybe not in your immediate family. And then it's tough for providers first starting to look into soft and velvety skin too. You might have to go feel some people's arms and try to see what the difference is that you feel underneath your fingertips. Velvety skin, as you drag the fingers along the skin itself, velvet catches a little bit. So it's almost like you catch the top layer of skin and there's a catch and snag. That is something that you have to train yourself to feel and do. Some people can feel it, some people cannot. Mild skin hyperextensibility and feature A, I will talk through a little bit of these and explain why we're looking at all of these. So mild skin hyperextensibility is actually looking to make sure that your skin isn't too stretchy. So we're looking for a 3 centimeter pull. It's actually non or non-dominant hand goes to the dominant forearm and you grab skin, fat, everything underneath and you give a pull down. Okay. And you see that I have a lot of skin pull. We're actually not looking for that with hypermobile EDS, right? We're looking for about a 3 centimeter pull. Okay, this is the official test is forearm skin underneath. I look at other spots on people just to see, are we seeing this globally throughout the body or did we just pick a funny spot where there's some skin laxity? So I do check throughout. But it's important to note that we're looking for a 3 centimeter pull for hypermobile EDS. Anything more than that, then we start being suspicious that there might be some other type of collagen presentation, classical EDS, something like that. So that's why I always tell people we're not necessarily looking for a yes or no. This is just to guide us through, do we think that there's a connective tissue problem? And then what more care does this individual need? Stretch marks. So we look for stretch marks, especially abnormal stretch marks. Did they appear too early? Again, I'm not going to go through the details. I could pick this all apart, but it really does tend to limit women, especially after puberty in a few of these categories or, after childbirth. Pysogenic papules on the heel. So for those of you that have them and don't know what they are, this is what they are. For those of you that know what these are, like we giggle because all of us are like, oh my gosh, I was always wondering what those were. And basically, I had an individual come into the clinic a couple of weeks ago that called them feet hernias, and I really like that term now. So pysogenic papules are like feet hernias because again, now we're seeing abnormal connective tissue in multiple different places, right? It's not just that we're having connective tissue problems with the ligaments. It's not just collagen in the ligaments, right? We're seeing differences in the fascia for some people. So the heel pad is actually contained with fascia, so it contains it in there. But if you have any tears or loosening of that fascia, you actually have the fat that pushes out. It's like a little fat hernia or a foot hernia that happens in that area. So that can happen for some people. We do the test is to check this with them weight bearing, so they're actually standing, so that you might be able to see this a lot more pronounced. And you check inside and outside of the heel on both sides. It should be present on both sides, multiple for a positive test. And there are some people that have them even without standing. I have seen that. Hernias. So abdominal hernias, hiatal hernias does not count, but has an individual had abdominal hernias even from surgeries, repeated repair, inguinal hernias, things like that. Atrophic scarring is another big one. So this is, I think we always feel like we should be looking for this in clinic and, oh, we'll be able to see if somebody has atrophic scarring. And I can't tell you how many people I've met that don't have scars, which is not normal in my life. I just feel like I have so many to be able to show, but some people just don't have scars. So it's already a point that you can't even count for them. That's why I say this is just to help guide us in thinking, is there a connective tissue problem or not, right? But the way that I describe scars is when your scar heals, we should see a piece of thread. We shouldn't see a piece of yarn or bigger. So really should be woven together pretty tight. But if we start seeing multiple areas where it's thicker, like the width of a piece of yarn rather than a piece of thread, then we might start thinking when your connective tissue tried to repair itself, there's something not as efficient, right? So again, multiple situations, multiple different tissues, we're seeing it pop up more like a genetic connective tissue disorder, right? Prolapse. So prolapse is something else that we look at. I'll tell you, most women don't know if they have prolapse unless somebody has looked in their pelvic floor for them, which a lot of individuals, it's getting better, but don't see pelvic floor therapists until after childbirth, right? It's becoming more common to send people out earlier or preventatively for this care. But it's not as common as it should be. And I am hoping that this starts to pick up and maybe we send people for at least external screenings with an individual to look at the pelvic floor just to be sure that there isn't anything that can be helped through working on this diaphragm group that's down there. Dental crowding and higher narrow palate. Now, a lot of times your provider might have to check that for you because these are things that we consider normal. You're given a palate spreader when you're younger, and those are, you can reword it a little bit as, have you had teeth removed ever because they didn't fit? Did you ever have a palate expander? Because or with braces or without because they had to fit more of your teeth in. And then has anybody ever commented on how high your palate is? So a little rewording might be helpful. And then it might have to be actually investigated in a clinic. Arachnodactyly and Walker sign. I don't have positive signs, so I always tell people I'm awful at demonstrating these. Arachnodactyly and Walker sign is looking for arachnodactyly, or sorry, Walker sign and Steinberg is looking for long fingers, which is not always something that we see. So again, it may or may not be on the next clinical diagnostic criteria. I don't know. But the Steinberg sign is sticking the thumb through and trying to get it to stick out the other side. And you'll actually see people that can get their whole knuckle and past out the other side of the hand. And it's not just thumb hypermobility, it's actually long fingers as well. And then the Walker sign looks at long fingers by asking you to overlap your thumb over your pinky. So it should overlap that last part of the digit, like over the fingernail, and that would be a positive Walker sign. So I actually don't have too many individuals that have had that pop up as positive. Arm span to height ratio. So you actually measure fingertip to fingertip, and then you take that and put it over their vertical height. So that's looking for something longer than one or a greater ratio than 1.05. So you have to do the math. I will be honest, I don't round up with this. So if they're 1.049, I keep it at 1.049 because again, we're just looking for the presence of connective tissue disorder. We don't necessarily have to label everybody unless they do want to be labeled, or it changes care locally where they are. And this is something I have had a few people that a lot of people come close to this. I had one who actually tested at 1.08, which is pretty darn long. So this is called more of a Marfanoid appearance with the long limbs, so like Marfan syndrome. So we are, of course, referring that individual out for further testing. But that's why this test can actually help open up the window to other conversations, right? And that's really all this should be, is a conversation of what you look like and what you need. Mitral valve prolapse, so heart murmur, mitral valve prolapse in the past, or even currently with this test, and then aortic root dilatation Z-score. I always used to laugh at this and ask people, "Oh, did you have your aortic root dilatation Z-score tested?" And I'd laugh, and I've had two people come back and say, "Well, yes, I have." And interestingly, they were both over 3, and nothing was said about it. So again, just refer them back to their provider just to double check, and actually the measurements were exactly the same, so they just need to be monitored. But most people don't have an aortic root dilatation Z-score, which would come in an ultrasound or an echocardiogram. Okay, so feature B, I always tell people that I ask this in 2 parts. And also it's important to understand this is a very, all checklists are limiting, right? When you make it into a checklist to try to fit somebody into a box, it's going to limit quite a number of people that don't come in part of that box. And we see this with individuals that have an adoptive history, right? Or they might not be in contact with their family members for whatever reason it might be. So this would completely take out a criterion for individuals that have been adopted or do not speak to their family or have a relationship with them, or they don't have family around anymore. So this can be a limiting aspect of it. But for those that do have family history, the way that I phrase this in 2 parts, because it's the information that's important, right? It's all of the information. It's not just the checklist. But I always ask if there is a positive family history, if somebody's already been diagnosed in the immediate family, right? First degree relatives with hypermobile EDS. That's my first part question. A lot of people are no. My second part question is always, do you think anybody in your family has it? And again, this is really important to follow trends and patterns within a family, and looking for anything else the individual should be tested for is to learn about their family history, right? So two-part question for me. And then criterion 2, feature C, and it, a lot of people in the hEDS and HSD, they kind of almost roll their eyes at this question. I always tell people, don't laugh at my questions, because chronic pain is so frequent. And I actually don't know which one in the research these days is is taking the lead, whether it's chronic fatigue or chronic pain. But gosh darn, do they battle in this population for which one's winning for the day. So I've had a couple people who have more instability than they do pain. And again, that would be a conversation of, oh, that's interesting. Why? Or why do these individuals have more pain than the ones who just have more instability, right? So the questions that we ask is basically localized joint reactions. So do you have a joint that you can point to that has pain that will last for more than 3 months at a time, right? So musculoskeletal area, bone, joint, tendon, something like that, that you can point to. Is it in 2 or more areas? Do you have a wonky shoulder and a wonky ankle? Now, the chronic widespread pain, also looking for more than 3 months at a time at some point, right? Like this has happened at some point. And that, rather than taking your finger, is you kind of like wave a hand over. Like, oh no, it's like it's my shoulder into my neck into my head, or it's my back into my hip into my pelvis. So that's more of the chronic widespread pain. The recurrent joint dislocation. So this I read verbatim for people, and I'll just like I was talking to you in clinic, I'll do it right here. But have you had recurrent joint dislocations or frank joint instability in the absence of trauma? What that means is, without an injury happening to a joint, do you have any joints that feel like they slip out of place, feel wonky, give out, are unstable, or that you don't trust? And then tell me what they are, right? Because well, depending on the profession, like physical therapists, occupational therapists, we need to know what's bothering you. What are the joints that we should focus on or stay away from, right? Just for file it away for future reference. Okay, in criterion 3, what we're looking at is, and sorry, my numbers are a little bit off here, so I just confused myself and we had to restart. My numbers are off, so stick with me. Criterion 3, number 1, is actually looking at skin fragility. And with this skin fragility, it's looking at splitting skin, so it's not easy to bump and bruise, it's easy to bump and tear. Which is uncommon. So again, it's making us think of something like classical or something like that. So I tell people, I'm not looking for a yes or no. I just want to learn more about your body. Is it aged, paper thin skin that you or somebody else has in your family that it might split when we bump it? And if you look, um, we're actually looking at the number 2 that's embedded in number 1. So have they been tested for autoimmune conditions? Have we ruled out RA and lupus? Now, if they haven't been ruled out, then we actually can't use feature C, or if they have been ruled in too, we can't use that that feature C for pain to count as a positive towards this test, because we need to make sure that we're treating the right thing. And yes, we can absolutely have somebody that has lupus and an EDS. We can have somebody that has Sjogren's and EDS, but we want to know if they have both. So we really don't want to trade off one diagnosis for another. So, and that's important to understand too, because even if we can't fit them because of an autoimmune condition into hypermobile EDS because of this criteria, then we have to remember to consider them potentially for the generalized hypermobility spectrum disorder, so we don't lose our focus in all the things that we need to work on. So somebody might need more Sjogren's based treatments, and then we come back to the EDS part of it later. But we have to make sure that we're ruling out all the conditions, and that's what number 3 is as well. We're looking at alternative diagnoses. So other things that might cause hypermobility. So has Loitz-Dietz, Marfan, things like that been ruled out, that are typically things that we can test for with genetics. So if it kind of looks like a connective tissue disorder, and there's especially some questionable things that are popping up with family history or with their own personal history, then we might as well have it ruled out genetically of the other conditions that we already know about, right? I think information is power for a lot of people, but treatment-wise, you don't necessarily need a specific diagnosis depending on your profession. Like for us that are in the rehab world, of course, I want to know if you have a connective tissue pathology, but I'd like to start working on it. Not all professions can do that, but it's good to know all the information if we can. Okay. So what does this all look like when we put it together, right? So yes, we have, again, hypermobility is there, but then we have this multi-system involvement. There's going to be an abnormal presentation of connective tissue and of the response to stressors as well, and to healing. So that's kind of what we're looking at with this checklist, right? Whether it's a checklist and we're fitting somebody into hypermobile EDS, or it's a checklist and we're fitting somebody into hypermobility spectrum disorder. What we're saying is there's an abnormal connective tissue presentation, abnormal response to stress on the connective tissue, and abnormal healing response as well. We can look at multiple different systems that are involved, right? Because connective tissue goes everywhere in the body. And this is, I know I talked for so long already, but like this is the important part coming up with the clinical presentation. So we get so hyper focused on joints, we forget that skin is actually, whether we're talking about collagen or other connective tissue components, there's a connective tissue disorder. It's going to affect in different amounts in every person, right? This can vary person to person, and in that person, it can vary day to day, even for some people. But it can involve the skin, it can involve the joints, other connective tissue that's in the body too, maybe fascia, maybe ligaments, maybe tendons, maybe it depends on the genetics that are involved. The gastrointestinal system, definitely. The neurological system, for sure. The cardiovascular system for some, endocrine, lymphatic, all of these things talk to connective tissue or are composed of connective tissue. So that's why it's important to understand, are we dealing with hypermobility or are we dealing with an underlying connective tissue disorder? Very, very important. Okay, so skin, there are gonna be lots of skin stuff that pops up on the skin. Talking about more of the connective tissue component and not the inflammatory mast cell component, that's different talks. But if we're just talking about connective tissue, we can see that the softer velvety skin that I was talking about, and even what's called a doughy texture. So even for those that work out a whole lot, like there's just a little bit more of a doughy feeling to the skin and underlying tissue. Skin can split with minor trauma. That's more of classical type of EDS that we see, but sure, we could see it. Everything's on a spectrum, right? We could see some of that with hypermobile and HSD possibly. The skin hyperextensibility for sure. We typically see it more on a 3 centimeter pull, so it's stretchier than usual, but not super stretchy. We can see slow wound healing. Now, this can be a connective tissue component, and mast cells can certainly slow this down if they're not cooperating, but we can see it just from the connective tissue aspect as well. Cigarette paper scarring, it actually looks like cigarette paper, so it has more of like that wrinkly tough texture to it. That's more common in classical EDS. Maybe we're seeing something similar though, but the atrophic scarring is much more common in HEDS and HSD. Easy bruising might happen. Hemosiderotic plaques on the shins, so on the shins of the legs, it's like a discoloration, like a brownish color that can develop on over the bone, and that we more see with classical and periodontal EDS. But just to note, like that's in the connective tissue spectrum. These molluscoid pseudotumors and subcutaneous spheroids are basically things underneath the skin. So bumpy things underneath the skin, and then pyogenic papules are those little hernias. And actually, you can have pyogenic papules on the feet, but another place that we see them can actually be on the wrist too. And I can't see mine too well, and that's because it's the wrong side. But they can actually exist in other spots too. Now, joints. Okay, so this is what we do focus on a lot because I think this is where the conversation started. It's not where it's going to end for most people. But what's important to understand here is that the hypermobility is on a spectrum itself. Not everybody is falling apart all the time, right? There are some people that have more mild forms of hypermobility, and there's people who have more severe forms. And there are a lot of things that happen in our body and to our systems that can also affect hypermobility. So we can see this waxing and waning in one person that's experiencing hypermobility, right? It's a worse day, it's a better day. That doesn't mean that they're making up their instability. It means that there are other factors that need to be under control to bring them back down to their baseline of stability. So the way I see it too is that there's actually some potential of things that we can work on to stabilize if you have that waxing and waning that's happening. Again, you can have somebody that's just a little bit unstable versus somebody that is, their ankles just don't hold together. They have to brace them all the time. Very different. You can have recurrent joint dislocations or subluxations, and these are not necessarily painful. It's very important for our providers to understand too, is that if you feel like their shoulder is super loosey-goosey, but they're not flinching or making faces, it doesn't mean that they don't have a hypermobility problem. It just means that there's probably less inflammation in that joint, which is good. Like, we're not necessarily going to change somebody's hypermobility, but we can change the inflammation that's on top of the hypermobility with time, hopefully, and help to stabilize the joint around it. So I think that there's this misconception that everybody needs to be dislocating and in pain when they do it for hypermobile EDS or HSD, and that's just not the truth. We can even have just micro instabilities at the hip for a lot of people, and a lot of times they're brushed off, but that can actually create a lot of pelvic problems, low back problems for individuals. So please don't brush off minor instabilities. They should still be treated with a specialist for sure, or at least teach you how to stabilize them in acute stages and then long term as well. Foot deformities, they can be there. We see this more with other types of EDS for sure, some of the rare types, but club foot or flat feet, so a certain shape to the foot, that usually happens, club foot, or flat feet is much more common with hypermobile form of EDS or HSD. This congenital progressive or non-progressive scoliosis or kyphoscoliosis. So yes, we have the kyphoscoliotic type of EDS, but we do see individuals that have spinal involvement with the symptomatic hypermobility group, right? And sometimes it is what we call progressive or non-progressive, and it can be congenital, you're born with it, or it can be functional as well. And that's where, especially our functional group, we've got to get you to the right people that teach you how to work on spinal alignment to support that spine so that it doesn't become progressive. There's actually a lot that spinal specialists, especially in the rehab population that are trained to work on scoliosis, can help teach you to live with a better spine position, even with scoliosis. Congenital hip dislocations or hip dysplasia. Congenital hip dislocations, that moves more towards arthrochalasia EDS and that amount of instability. But we see a lot more individuals with HEDS and HSD that are being diagnosed with hip dysplasia, right? So hip dysplasia is a change of the socket position, the ball and socket position of the joint. Chicken or the egg type scenario where they think it comes from, but micro instabilities when somebody is growing and developing can change the shape of this joint, and it results in this hip dysplasia, which also feeds into hip instability because of the altered shape. There are things that can be done for that. We'll talk about at a different time outside of surgery too. Muscle weakness, hypotonia, and or delayed motor development. And again, these are all on a spectrum. Delayed motor development, that's a little tricky how it's worded here. We could say altered motor development. So we don't always, with kids, it's not linear how they progress. So if we're seeing a delayed motor development, they might spike in verbal things like that. It's also altered motor development. So if we're seeing kiddos that jump right from like belly crawling to trying to walk and they skip crawling, we might think, oh, they're so advanced, they're trying to walk. But actually, they might be skipping the reciprocal motion of crawling. That's actually very complicated for connective tissue to stabilize with the neurological pathways. So it's altered motor development. Let's call it that. So it's a change that we would typically see from the normal up slope. That kind of, and again, it's not linear, but we might see bigger jumps with these kids where it's delayed, 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 and then boom, they skip something. It might be compensation. Chronic widespread pain, also common. Again, we can have lots of local pain too. Okay, so to go back to the Baton score and talk a little bit more about joints, right? The Baton score is something that we use for all providers out there that might not be taught how to test for hypermobility. but there is two tests out there that test for hypermobility that this is what I jump to if the Baton score comes back negative and there's still something that looks different in this patient that might have a connective tissue pathology, and we just want some validation for the medical team, right? So the LHAT testing and the LS testing are the two tests that a physical therapist, occupational therapist might be able to do this LHAT testing, and heck, even orthopedics too, and our DOs, and anybody who is working with goniometers and might want to look into this. But we look at shoulder flexion, so how easily can they bring their arm back behind them? Shoulder rotation, is it 180 degrees or more? And this is not like cranking through it, and this is lying down on a table. Elbow extension, so we do same as the Baton, look for the elbow hyperextension. The elbow varus valgus is actually a joint laxity test that PTs are taught to do. The radial and ulnar deviation, or radial and ulnar supination pronation, is how far you can rotate palm up, palm down, and we measure at the forearm. So do they have excessive motion there? Sulcus sign, so some people can do this on command, where they cause a sulcus sign. So that if they don't do that, or everybody's uncomfortable doing that, some patients know that it doesn't cause an issue. Some patients it will actually cause an issue. So the PT, the way that they could do it is by holding the end of the humerus bone, so the end of the elbow, so above the elbow, but on the end of the arm, the upper arm, and they gently pull down away from the shoulder socket, and you might actually see a divot in the front of the shoulder that's called a sulcus sign. Distal radial ulnar joint play. I've got so much stuff on my wrist, I apologize. So that's looking about bringing this down. So can we bring that down? How much play do we have at that distal radius ulna? Okay, so if the ulna can pop down in pronation versus supination as well, you test it there. It's definitely a test for a hand therapist, OT, or a PT. Wrist flexion and thumb abduction. This can be done with the elbow flex, but this is the EDS gang sign, the thumb to the forearm. MCP extension of fingers 2 through 5. So that's actually, it's your index to your pinky. And you can measure any of these and look for extension over 90 degrees. And the reason why I like this too is that you can bend the rest of the finger in here, so we don't have to stretch the tendons, which are tight on some people. Wrist, that's actually ulnar deviation, so it's radial and ulnar, so it's supposed to be RU, sorry. Basically, it's that windshield wiper, and we're measuring to see if it's over 60 degrees. Hand span is a ratio measurement that you do. And then, so the finger span to the wrist crease, and then to the middle fingertip. So just a ratio to work out mathematically. And then wrist extension. So this is actually, it's looking to see how far can you push the wrist back into extension, but you do it on the edge of the table. And I find a lot of people that are hypermobile are doing this to stretch the wrist anyway. So they might already know exactly how to do this, but you just put your hand at the edge of the table with your thumb over the edge, so resting on the side of the table, and then you shift your weight over onto it into a lunge position, and then the therapist measures it. And then we have the LS testing, which is looking at the lower body. So you can see, especially with the LS testing, we are interested in your lower body. The Baton score is just knees, right? And again, that can be very, very difficult for somebody to measure that hasn't been taught how to measure it. So this is a little bit different. So the LS testing goes through these 12 different pieces here. Hip flexion to the chest. So basically, can you bring your knee into your chest, and does it come in pretty easily? Is it resting against the chest? Does it feel like there's not a whole lot of resistance? We have hip abduction. So this is actually letting the knee rotate out to the side of the table. So kind of we call it hook lying, but lying on your back, knees bent, feet flat, and you let the knee rotate out to the side. And we're looking for within 1 fist width from the knee to the table. So if it's fist width or closer, it's considered positive. Knee hyperextension is actually tested. This is a little bit easier now. I feel like this one actually might be a good one to shift in for the Baton score. You have the person lie down on the table and you stabilize above their knee and you lift their heel up to see if we're getting the hyperextension at the knee. So again, we're looking for a couple inches, I think it's 2 inches or a fist width. Sorry, you'll have to look that up, but we are looking for the hyperextension there. I just think it's an easier way to visualize it for a lot of people that don't know how to measure the angle of the bones. Anterior drawer test and knee rotary instability. These are typically ones done by physical therapists, but it's basically testing not just the kneecap, but the big bones. Do we see a lot of rotation and a lot of movement this way, which can happen in individuals? Ankle anterior drawer test is another ligament test that we do for sprained ankles. Subtalar joint inversion, that's another one that we do for ankle sprains. How far can it rotate inward? So we're looking for excessive tests, or what physical therapists have been taught are positive tests, which might not have come with an injury. Mid-tarsal joint inversion, and then also AB and adduction. So midfoot mobility is what we're looking for. So this, you'd have to see a specialist. It's not really something I can describe on here. But PTs know how to look for mid-tarsal inversion that happens, and then ab and abduction as well. And then hallux extension, that's just, can your big toe come back more than 90 degrees from that foot bone, right? Like we're looking at the thumb. Does your great toe do that as well? Does it easily come back to 90 degrees? And then the excessive subtalar joint mobility is looking at when you stand and you relax your feet, does that arch collapse to the floor? So you can just see it just really, there's a lot of things that's looked at here. And for both of these, I do believe it's a 7 out of 12. So you add 1 point for either side. So you'd have a number out of 24, and then you'd reduce it down to out of 12. And if you have a 7 out of 12 or higher, it's considered positive for the LHAT or the LS. Okay, so other areas of the body. Well, so many things can happen, right? Some of the things that we see are hernias. We talked about the connective tissue, the fascial component might be different. We can see umbilical, inguinal, we can see post-surgical hernias as well in the abdomen. Bladder diverticula can happen as a diagnosis, repetitive pneumothorax, which is typically with the more rare types of EDS. But again, we can see things overlapping too. Microcornea, scleral or corneal fragility, keratoconus, keratoglobus. So eye stuff, right? Eye stuff can happen. There's connective tissue in the eyeball. Does this mean that you have a certain type of EDS? It does not. It just means that there might be a connective tissue component. But of course, if we have these things coming up and the suspicions of a hypermobility spectrum disorder, or HEDS, and we want this monitored, right? Until we have all the genetics that we're looking for on all of this, just keep it monitored. Pelvic organ prolapse is something that we see classical in our hypermobile population as well. And then vascular issues can happen, but they are rare outside of VEDS, sometimes classical EDS. So yes, they can happen, but they are rare, right? And even within VEDS, we see a spectrum of involvement even with that group as well, okay? But just something to consider, that if we are concerned about vascular stuff, then we should probably refer out for a vascular screening, right? Pain presentation, so many things, right? And I talk more in my neurological presentations and dysautonomia, things like that, as to all of these neurological connections and pain amplification that happens. Lots of things can go wonky because the connective tissue is part of what's keeping inflammation out of our system, and the inflammation is what can drive this neurological response, right? So if you have a lit up nervous system, it's going to be reading these highly responsive pain signals. So you're going to have hyperalgesia, which is an increased reaction to the pain stimulus that's provided. Allodynia is abnormal pain responses to whatever is provoked in the patient. There's neuropathic pain, so the neurological type of pain. There's central sensitization, which whether it's central sensitization, CRPS, RSD, I think there's from what I've seen, almost this guilt factor of how did I end up with this? And this is not psychological. This is not something that is mental health in that aspect. This is a neurological electrical firing problem. This is different than psychology. Yes, it can affect your psychology if you don't feel well a lot, but central sensitization is actually this miscommunication between the central and autonomic and peripheral nervous system. So something has just happened where it's not communicating efficiently and it hasn't been retrained yet as to how to send out and receive signals. It is not something that is, it's neurological. It has to be retrained just like any other muscle in the body. You have to reprogram it. And there's some programs out there in different ways to do that, but central sensitization is more common than we talk about, and we are talking about it more commonly now. But it's just to understand that it's not something that we do to ourselves. It's just something that happens to our neurological system that does need to be addressed like any other diagnosis in the body by an appropriate provider who's going to treat it correctly and understanding the neurological components. And the same for CRPS or chronic regional pain syndrome and reflex sympathetic dystrophy. That is a miscommunication between the central autonomic and peripheral nervous system. And typically those patients are very much stuck on that sympathetic ledge. They're not getting into freeze. They're stuck on this sympathetic ledge of the signals just constantly firing and being stuck there. And that is a dysfunction. So we have to reprogram the nervous system, teach it how to communicate with one another. And those rehab plans look very, very different than, lifting a weight or stabilizing the hip, but should be addressed if there's a neurological component. And then we can have visceral pain as well. The viscera is surrounded by connective tissue, and we know that there's neurovascular stuff that happens in some people too. And it's just a world of neurovascular connections in this abdominal space. So organ pain can be a problem for some individuals that feels like joint pain, feels like back pain, but might need to be investigated as well. And this isn't meaning that organs are rupturing. This is meaning that organs are stuck, bound in place, just like a tight muscle, things like that. And if we get to the right person to free it up and restore connections, that it can go away. It's just a different provider. And then, so all of these abnormal communications between the different systems, right? So when there are chronic pain presentations, there is a miscommunication that is happening somewhere, and we need to retrain the body. The GI system, so many things. I'll have separate talks, of course, on this, as I will the neurological and pain systems. But dysphagia, so difficulty swallowing, dyspepsia, reflux, chronic gastritis, bloating, nausea, vomiting, abdominal pain, constipation, and or diarrhea, swinging back and forth between the two can happen, abdominal hernias, and dysmotility and our gastroparesis, so basically slowed or fast motility. All of these are actually pretty darn common when there's a connective tissue pathology. How severe it is can really wax and wane for the individual based on what their immune system is doing at the time and their autonomic nervous system in regards to stress or whatever else is being processed in that autonomic nervous system, right? That can do with neurology in itself or the immune system connection too. But just to show, this is a lot of stuff, right? And I think that we normalize GI issues too much in this country and other places as well. But these are not normal symptoms to have. And a lot of times we think about pain and joint stuff that needs to be addressed. And I just don't want people to forget about their GI systems because we think IBS should be normal. It is not normal. We need to work on it, especially for those of us with connective tissue disorders. We really need to stabilize all the systems that we can. There's so much that goes on in a body that's dealing with altered connective tissue, especially if we added inflammation to it. And that's the domino that typically topples all of this over, that we end up with all of the things. Neurological system. I will keep this short because I love talking about this stuff, each one of these things on here. So I will do it in all of their own separate lectures. But again, once you add inflammation to neurological connective tissue, it is a wildfire in the system as to how it might present and what the person might feel. So neural inflammation or hypersensitivity, so tingling, numbness, things like that, especially with minimal contact, or I'm not doing anything and I feel tingling. That can happen from neural inflammatory responses, segmental kyphosis or instability. So you have not great alignment between spinal segments. Small fiber neuropathy can happen, which affects the small fibers more distally out towards our periphery, like our skin. Neural entrapment, where nerves get stuck in between connective tissue or bone in a connective tissue, so it pinches down on the nerve. Tethered cord syndrome is an issue with the lower end of the spinal cord, which I will talk about ad nauseum. I am sure there's already a 4-part neurological inflammation that starts to explain that on YouTube. Dystonias, so abnormal muscle twitching and movement, especially repetitive, that happens. Tarlov cyst syndrome, which is a cyst-like formation that develops off of like spinal cord nerve root area. That's abnormal cerebrospinal fluid movement. Chiari malformation can happen up near the brain stem, or cerebellar ectopia can also, it's kind of like a lesser version, anatomically, not symptomatically for some people. Upper cervical instability might be present, so instability in the upper part of the cervical spine or the neck. Cerebrospinal fluid leaks are more common in this population because the dura is made out of connective tissue. Intracranial hypertension or hypotension, so changes inside of the pressure in the head, and dysautonomia, which is abnormal autonomic nervous system response. This all sounds scary, and it doesn't feel good for sure. But this is, I'd just like to say that these are my specialties, and there's so much improvement that we can have for people if we understand how they ended up with those things, and we can work on that to help calm and what I say is bring their system into remission. I don't necessarily think everything is curative, but we can certainly bring people into remission. So not to be scary with the neurological system, there is just a lot of stuff that once you add inflammation to abnormal connective tissue in the neurological system, it can cause problems. There are psychological and behavioral presentation correlations. And remember, correlations, we're not saying anything causes anything yet, but we do see anxiety disorders, possible personality disorders, eating disordered, and more importantly, disordered eating, which we'll talk about probably in the GI stuff over time. Schizophrenic, panic, and then phobic cluster disorders, attention deficit hyperactivity disorders, developmental coordination disorder, autism spectrum disorder, and learning disabilities have all been linked with hypermobility. Okay, again, that's for another talk, right? But this is just to show you all of the things that might be affected. And we're certainly not saying every single person has all of these things. That's not how it works. But if we consider what abnormal connective tissue could do, depending on the person and their exposure and their story and what's happened to them, we could be seeing some things that might need to be addressed across multiple systems. But the reason why this is so important to understand all of this and what could be present is to understand that we do not put people into boxes. Okay, no two people will look alike. It's the whole idea of the zebra, right? Every zebra has a different stripe pattern, just like all of our zebras will have different symptoms and presentations and different recovery outlooks too. Okay, and that's really what I want to explain in all of my presentations. All this one does seem a little on the negative side with all that I bring up that could be there, but these are all things that, again, if we understand how the person's connective tissue was affected in their personal story, we could figure out how to support them better. So all of these things could be present, and in fact, a lot of people have something in each one of these categories, but we don't necessarily have to address all of them right away. We can start picking pieces to address over time. But just especially for our providers, our caregivers, our friends, and our family to understand, this goes across a lot of different systems. It can make you feel very unwell. It can make things look very, very weird, but they are there. And it's an interesting presentation of multiple problems that can pop up, right? So most of us, like most nearly all of us, are not making things up, right? I'm sure there's been a story out there and maybe somebody was, but it can just look like a lot of things and really come down to the fact that it's connective tissue and it happens to exist or coordinate or communicate with multiple different parts of the body, right? So the clinical presentation of HSD and hEDS does typically involve hypermobility because there's a connective tissue problem. However, hypermobility is an indicator that there might be a connective tissue disorder that's present, might affect other connective tissue, and that's the big part that we need to know. In other systems of the body, it's not just ligaments. So multiple systems are usually involved. And everybody's presentation and treatment is going to be unique to them. When you're first starting on this journey, and first starting actually covers a long period of time, actually, because as you just saw, there's a lot of things to go to. There's a lot of things to check on. Are we supporting you in the right way? Do we look into all of the pieces that we might have to address now or later? What's your full picture? What's your full story? It's important to know what you're connected to do is doing through your whole body. We don't have a whole lot of providers that cross into those different categories. I only know of one neuroimmune gastroenterologist, right? So we don't have a lot of specialists that understand how these systems work together. And it's fascinating because the gastrointestinal system is 100%, well, not 100%, but the gastrointestinal system is primarily innervated by the autonomic nervous system, right? The motility of the gastrointestinal system is from the nervous system. So we need more neurogastroenterologists out there, but we just don't have them yet. So this is complicated, this is confusing, and it's frustrating for individuals that are going through this process because there's not a lot of understanding of how this all works together, right? So from the provider side of it, please have patience with your patients. From the side of it for our patients, we have to have patience with our providers too, right? Because we don't have a lot that know what they should to be able to help us, because that's not what our medical system currently looks like. And even in our non-traditional medical fields, there still aren't a whole lot of people that specialize in all of the things and how all of the tissue talks to each other. So this is a really tough journey from both sides, right? From providers that want to help and from patients that want to be helped. But if you hang in there and piece out the right providers to start to sort through all of your presentations, then you might start making some headway. And there's always something to work on. There's always something positive to work on. All right, and then all my references for the stuff that was in this presentation, always a long one, right? There's always so much information. But thanks for hanging in there. Just a general overview of all of the systems that are involved, a little bit about how we diagnose with the clinical criteria. So thanks for hanging in there. Until next time.